Life now. So I guess we'll begin with the next aspect after studying anatomical landmarks. That would be diagnosis and evaluation of our complete denture patients. Now, overall, if you see, diagnosis and examination of a patient is a practical topic. It's a case history topic, something that is not a very theoretical topic. You need a patient in hand to explain it. But there are some sections of it and some classifications mainly regarding different structures, different morphological anatomy of structures, which is asked in our exams. So let's try to understand those specific areas only. Generally, if we see and if we examine our patient, just a second. If we examine our patients, what we would usually have is a general physical examination of our patients. That would check the general bodily health of our patients. Then we do a local examination of our patients of the particular site. So your maxilla, mandible. Apart from that, what we generally obtain from our patient is a general history. Then we get a medical history. We get a dental history. These are the different histories that we obtain from our patients. So, grossly questions do come from these areas that help us understand our patient thoroughly. I will not go sequentially explaining everything. The reason is that it is unnecessary information. I don't want to overload you with unnecessary information. So, very specific information that is asked to you in exam. That is where we begin. That is where we give a focused information to our students only, so that you know what to focus on in our exam. So the first important point is the role of occupation. When we are taking a general history of our patient, there is a role of occupation. What is the role? Working professionals, if they are present. Working professionals, what will they prefer? They will prefer a straighter, aligned appearance of teeth. That is something that we derive out of case history. If our patient is a working individual, that individual will prefer a straighter, aligned teeth, right? Someone who works with musical instruments or someone who is a teacher, so something that is relevant to voice maybe, someone who works with musical instruments or is a teacher, that person will not prefer a removable prosthesis. Or if you give a removable prosthesis, what is 100% like very, very important is what? Palatal contour of the prosthesis. Palatal contour of the prosthesis is very important when we are talking about your any case that has any profession. So musicians, teachers, someone who has to speak. These all the phonetics should not be affected. These are or any particular musician who plays what? Wind instruments. Blowing that is there. You need to be very careful of the palatal contour that is there. So this is one aspect from case history which I feel is important and you should know, or questions could be asked. The second aspect from the case history which I have seen very commonly is the Milus house, Milus M, right? Classification. You must be thinking, what is this? What is Milus house? It is house classification. The first name is Milus here, right? So house classification to understand the basic patient psychology. This is the patient psychology, which is, I always tend to forget the spelling of psychology, but psychology of your patient is from house classification. The first is called as a Philosophic patient. Now, what we have seen while teaching our students very commonly in clinics is all patients are philosophic. That is what they straightforward write in case histories, because it is easier to choose this option rather than evaluate the patient for the other three options. But let me try and explain you in very simple words what philosophic is. A philosophic patient could be considered your ideal patient for treatment. This is a patient who listens to you, who tries to understand you, is willing to understand the doctor's opinion, has reasonable expectations towards treatment. So if my patient has a flatter palate, and I tell my patient from the beginning that, see, your attention would be compromised here, and the patient willfully accepts that and or tries to understand around it, or tries to understand the limitations of a denture. Say the patient says that I want to eat eclairs with my denture, but that is not reasonably possible, right? So a patient who understands what you're trying to explain them, that is a philosophic patient who is willing to accept, has reasonable expectations. So leave aside the textbook definitions of it. Try to understand what exactly philosophic means. This is what exactly a philosophic means. Philosophic patient does not mean a patient just blindly accepting what you are saying. That is not philosophic. Philosophic is someone who reasonably understands what you're trying to explain, has a logic around the treatment. The patient who is willfully able to accept what you're trying to say, the treatment plan that you're trying to give, is able to understand mainly the limitations that the treatment has, and most important, has reasonable expectations towards the treatment. That is what exactly a philosophical patient is. So such a patient will give you a very good successful treatment, because a treatment is just 50-50, a 50% from the clinician and a 50% from the patient. So you will get a very good outcome of your treatment. So ideally, this would be your best patient to go with, right? That is what is philosophic. What do you understand by now? Exacting. Exacting is a very accurate, precise, or I would say a very demanding patient. A patient who wants very specific things from you, or who will question everything that you do. Why is it that you are doing this? What is the reason behind it? Why is it done only in this way? Why can't you do it in this particular manner? So somebody who is very methodical, very precise, very accurate, who questions everything that you do, that is an exacting patient. What problems we face with exacting patient is, it is difficult to gain trust of these patients. But if you actually trust of such a patient, that patient will become loyal to you always, right? So that is an exacting patient. The difference between a hysterical and an exacting patient is what? Hysterical is that hyper excitable patient, or a hyper emotional, or a hyper irritable patient. Exacting is a person who is very demanding of what he or she wants from you. So someone who will say, I need crisp white teeth only, which are very squarish and very demanding for exactly what they want. That is an exacting patient. Hysterical is what? A very moody, a very excitable state, or a very irritable state sort of a patient. That is a third variety. We call them a hysterical patient, right? That is a excessively apprehensive, hypertensive, hyper aware of what is being done, and very conscious of the treatment that is being done. That is a hysterical patient. So the patient is not actually concerned about what you are doing. The patient is very anxious around generally the treatment that is done. Exacting patient is concerned about what exactly we are doing at that time, why this exact treatment is being done, why not something else is done. So that is your exacting patient. And the last variety is a totally, as the name suggests, only indifferent patient. Indifferent means what? Someone who has no concern with what is being done or not. So indifferent patient is someone who has no interest in treatment, who has no. You have your crest of the ridge, right? So crest of the ridge, on the medial aspects. So together, it is forming a boundary for you. You have medially the crest of the ridge, posteriorly the pad area, laterally external oblique ridge, externally anteriorly the buccal frenum. The area that lies between all of them, the area that lies here in between all of them, that forms your buccal shelf area. Now with buccal shelf area, it is considered to be a primary stress bearing area. The reason for that is what? There are multiple reasons that favor it. There are multiple reasons that go against it, yet we consider it a primary stress bearing area. So what are the favorable reasons? If we see what are our favorable reasons, first is wider surface area. So you have a lot of surface area that helps you with the dissipation of forces. Second is that it is located perpendicular to occlusal forces. That is the second reason for it. Third is dense cortical bone. The super layer of it, the superficial layer of it has a good dense cortical bone present on the buccal shelf area. So dense cortical bone, a dense mucosal covering. Dense mucosal covering which is present, that is helpful. So all of these are favorable factors which helps with the property of stress absorption and dissipation. Right? This is why you have your buccal shelf area, which is considered your primary stress bearing area. On an average, if we see, it is usually 4 to 6 millimeters wide. Now, the good part with buccal shelf area is what? The crest of the ridge that is located medially. As in when resorption occurs, it becomes flatter. And when it comes down, the area widens. So that is an advantage with buccal shelf area, is that the area will widen and become more perpendicular to occlusal force. Initially, the crest of the ridge will be somewhat, see, I'll draw for you. Crest of the ridge will be like this, and this would be your area. When the crest of the ridge flattens and it comes downward, our area widens because now the crest of the ridge is moving far medially. So the area becomes more horizontal for us, and that is how you get a wider area that is favorable for deriving support. So that is one of the reasons why buccal shelf area is a good primary stress bearing area. Residual alveolar ridge, the same actually if you see as your maxilla. There are different morphologies and different shapes. If you have a high well rounded shape, definitely it is going to be better for you, right? Now, coming on to our limiting structures. Discuss our limiting structures of mandible. Let me just share the presentation. So I'll write down, the correct page for it. I'll write down our limiting structures. Now what we'll do is we'll just discuss the points of difference that are present from maxilla. So if we see our labial frenum, what will be the point of difference? Labial frenum in mandible has muscle attachment. It has a muscle attachment. When you have a muscular attachment, you need a wider relief for it. So the muscle attachment that is there is your mainly incisivus and orbicularis oris. Right? So muscle attachment that is present is your incisivus and orbicularis oris. Mentalis will also affect this area, which is the reason why you need to mold it very nicely when you're doing your border molding procedures, right? So mentalis is also important. When we open our mouth wider, orbicularis oris is going to be stretched. It will be stretched. It will be widened. So it is going to actually narrow down your labial sulcus. So that is our second point. When orbicularis oris will be wider mouth opening, it will be stretched. and the sulcus will become narrower. So we need to do a very good functional movement so as to attain a good peripheral seal in this area. Clinically, if I tell you one point, it is preferred to have a 2 to 3 millimeter thicker border to obtain a good peripheral seal in this region, but till the limit it is tolerated. If it is affecting the aesthetics by keeping a thicker border, or if you feel that it is dislodging the denture, then you should not go beyond the physiological limits, right? Microscopically, if you see, all of this will be made of your lining mucosa. So lining mucosa is going to be non-keratinized. So pressure or any border which is going to be present over there should be smooth, well-rounded, so you don't abrade your tissues in these regions, right? Fibers of muscles that we see, such muscles that we see here are usually horizontal. So when they are horizontal, when they are stretched, right, when the mouth opening is wide, that time sulcus will narrow down. So that is something that we need to take care of and not overextend it. Coming to now, this was our first one. This was our second one. Coming to the third one is our buccal frenum. We are just discussing the points of difference now from your maxilla. Buccal frenum, similar 3 point of your attachment. Posterior will be your buccinator. Anterior will be your orbicularis oris. And here you will have the depressor muscle, depressor anguli oris. Together they pull the muscle in 3 different directions. So you need to give a wider concentric relief for your buccal frenum. Otherwise there is a good chance. So you need to give I'll show you exactly. This is how the concentric relief for buccal frenum is prepared, right? So again, the fourth structure is your buccal vestibule, very similar to your maxillary buccal vestibule. There is nothing new that is different here. Lining mucosa is the same. You need to mold your muscles of mainly buccinator that are running anteroposteriorly. So they will dislodge the denture in this region, right? What I'm more important to discuss, from which questions are coming, is the influence of masseter actually at the distobuccal border. This is what I want to discuss in details with you. The influence of masseter on the distobuccal border. So distobuccal border is largely influenced by masseter, which is this muscle here. It's a muscle of mastication. You know the origin and insertion, very nicely explained by Sir in anatomy. So this distobuccal region affected by elevator muscle. Masseter is an elevator muscle of mastication, and it is mainly responsible for generating bite force during mastication. That is a key point of your masseter muscle. Now, when it contracts, it puts a inward bulge. Or rather, it creates an inward bulge of what? Of buccinator muscle. When it contracts, it puts an inward bulge in the buccinator muscle. So masseter is outside. If you see it 3-dimensionally, masseter is outside, buccinator is located inside. When the masseter contracts here, it pushes through the buccinator, which creates an inward bulge, and together this on the distobuccal border creates something which is called as the masseteric notch on the impression. So a very commonly asked MCQ question in your exam is the masseteric notch is created by the influence of what on which structure. So if we see the 3-dimensional orientation of muscle, masseter is located on the outer side laterally. On the inner side of it, or rather internal to it, would be a buccinator. When the forceful contraction of masseter happens, it pushes against the buccinator muscle that creates an inward bulge and creates your masseteric notch. So a very important MCQ question. I'm going to highlight it here for you so that when you go back and see this, you remember to read this portion up again and keep it in mind. It is the influence of masseter on buccinator. That is the answer to your question. Just remember, influence of masseter on buccinator is your masseteric notch. Right? A very important question for your exam. Now, the next part on the posterior aspect, which I want to discuss, is the pterygomandibular raphe. Now, initially I told you, we'll take a focused approach to preparation. Ideally, if I sit down, I could teach you anatomy and landmarks for hours together. But then I don't want to bore you with excessive information which is actually not relevant for your exams. So we are focusing on those areas, masseter, buccal shelf area, pterygomandibular raphe, which have repeated questions coming it. The whole idea of preparation of prostho with me is that rather than preparing you for something which is very offbeat, I would first consider that all students should do, which is your basic or which is the foundation of your prosthodontic learning. Once you're thorough with it completely, you're actually securing your main questions, and then you move to your offbeat questions of implants and other sections to score those extra marks. The reason is that your exam does not differentiate whether you've answered an easy question or a tougher question, or gives you more marks for tougher question. Your exam just evaluates all questions with the same marking, right? So then it is easy to target the questions that are coming more frequently and gain those marks first, rather than reading the offbeat portion first, right? So my focus for preparation is to teach you these aspects first and then move ahead with the slightly more offbeat questions. So every session we will move like this. We will first develop the foundation of our subject, the basic understanding of our subject, and then move to questions which will give you that extra brownie points in your exams, right? So coming back to now pterygomandibular raphe, what does it originate from as the name suggests? It originates from the pterygoid hamulus of the medial pterygoid plate, right, and attaches to the distal end of mylohyoid ridge, right? That is your pterygomandibular raphe. What is it actually? Pterygomandibular raphe. If we see laterally, it will be bound by buccinator. Because if you see mandible as a whole, the raphe comes downwards like this. On the outer side is buccinator. On its outer side is again masseter. On the inner side, pharyngeal muscles will come. So laterally, it is bound by buccinator. Right, but medially, it is bound by one pharyngeal muscle, which is your superior constrictor. Good to go. So coming on to pterygomandibular raphe, actually, pterygomandibular raphe, like I just explained, it is bound laterally by your buccinator muscle and medially by your superior constrictor muscle. So what I have felt around mandible is that you need to understand the three-dimensional anatomy and how different muscles are located. So very important picture which is there, I just explained it to you. It is there with me in one of our slides. Yes, exactly this. First, this is what is showing your buccal shelf area. So like we said, we have our frenum here. Anteriorly, we have our pad here. Posteriorly, then we have our external oblique ridge. We have the crest of the ridge. So together, that would make your buccal shelf area. This photo is again from Boucher's only that we have taken up. And the another important thing that I'm discussing is this particular image. It is a very important image from your Boucher's to understand the three-dimensional placement of muscles and ligaments which are present. So let us try to understand that. This is your mandible and your mandibular denture that you are seeing. at the posterior border of this denture, right? What do we see? The first structure that we see just lateral to it, a denture, and you just go lateral to it, right? This is the midline of your human body. Anything that will be towards this will be called medial. Anything that will be away from it will be called lateral, right? I hope this is something that you understand. So now, if we see here, the first structure, I am just drawing it here, see, that we see is this B. B is what? Basically, B is your buccinator muscle. So just lateral to your denture will be your buccinator muscle. It is a thinner muscle in terms of fiber, which is influenced by this thicker muscle, which is your masseter, which is much more lateral to buccinator. So now I hope you understand that the masseter will push actually the buccinator here and will create that inward masseteric notch, right? Posteriorly, if you see, if you broaden it actually, and if you see the first we saw our buccinator, the outer side we saw our masseter. Now posteriorly, if you see somewhere here, we have our pterygomandibular raphe that comes from the hamulus here and it joins actually at the mylohyoid ridge. So somewhat there is your raphe. Here in behind, just behind this denture, what we'll see is our medial pterygoid. Somewhere here, you'll see our medial pterygoid. And on the medial aspect, that means on the inner aspect, you see your superior constrictor muscle. So if I just erase all of this so that it becomes easier, in the central part here somewhere, you see a tendon of temporalis and pterygomandibular raphe. On the lateral aspect, you see masseter and buccinator. The medial aspect, you see superior constrictor, and behind your, or just behind your denture's posterior part, you see your medial pterygoid, right? So these are the different muscular attachments, and if we draw them, you see your raphe here, and you see temporalis tendon, and you see your posterior to that, you see medial pterygoid. On the lateral aspect, you see buccinator and you see masseter. The medial aspect, you see superior constrictor. So this should help you actually understand what is the posterior border of the mandible or the posterior third of the mandible. Now, why are we discussing posterior 1/3 this much? We'll tell you the significance of it. This is our retromolar pad area and the distal third, right? This particular region here, this is our distal third. Now, if we take that entire area, if they take the entire area like this, that is made, the posterior part, and you divide it into 3 parts, 1, 2, and 3. The posterior 1/3 is the one which is influenced mainly by these muscles a lot. It is mainly influenced by these muscles and the presence of these muscles. When a plethora of muscles are attaching at the posterior border, the chances are it will dislodge the denture by their movements. On the medial, on the lateral, on the posterior border, you see a lot of muscles. So the clinical implication here is that a denture base should extend till 2/3 of the pad area, and the posterior 1/3 is not completely covered. Now this is a clinical dilemma. Some cases it say you can cover the complete pad area. Some places it is written cover 2/3. Clinically telling you, we see the attachment and the movement that we see in our patient and then decide whether or not to cover it 2/3 or completely, right? So that is how we go clinically. Another important anatomical feature and reference point is that the pad area for occlusal rims also, we divide it into 3 parts, and the level of occlusal plane will be at the junction of the anterior 2/3 and the posterior 1/3. So this is where the level of the occlusal plane is. This is why the retromolar pad area and the posterior border of the denture in mandible is very important, because it helps you develop the plane of occlusion. It helps you develop the extent of your denture base that is there. It helps you understand your origin insertion of raphe, masseter, masseteric notch, bulge that is created by masseteric notch, and even your other muscles that are present in the surrounding area. So out of your entire anatomy of mandible, this is one structure, one area that one needs to understand here. INI CET recent paper, May 2023, had a question pertaining to this. So this is something that all of you should 100% be paying attention to always, right? Let's discuss now the lingual border of mandible. Lingual border of mandible, what will it have? You have your lingual frenum and you have your alveolingual sulcus. Now, I hope till this point everything is clear. If you can just drop in a message on our group. Shruti is asking, where's the link? I'm not able to find it. Shruti, are you able to join? Just refresh the same link. You'll be able to join. Rest all students who are actively listening, just tell me, are you able to follow or do you have any doubt till what we have covered? Since we are not interacting directly through a video session, I'm just asking you to post on the group. Just put a message on the group. Are you able to follow me completely what we have explained till now? Do you have any doubts? Just put in a message and then we can go ahead with the lingual border of mandible. Students, can you just put in a message? This is the last part of your anatomical landmarks and then we will shift over to another topic. So just let me know. Is there any doubt or should I continue with lingual border of mandible? Okay. Muscle attachment in retromollar pad area region. Okay, let us take this example. If this is the posterior border here, this is the posterior most portion, and if I see muscle attachments, the first thing that we see is buccinator. Outer to that, what we see is masseter. If we come medially, we see superior constrictor, which is a pharyngeal muscle on the medial aspect. So this would be medially, this would be laterally. Anteriorly, you don't have anything. Posteriorly, you have your pterygomandibular raphe plus tendon of temporalis. Behind that, what you see is your medial pterygoid, right? So you have superior constrictor, buccinator, and then masseter. Then just behind you have pterygomandibular raphe, you have tendon of temporalis, and lastly you have your medial pterygoid. These are all our muscles which are present. So Nihala and Cherry, are you able to follow what I just explained here? The muscular attachments, how many are we having in total? We have one raphe, we have one tendon, we have one medial pterygoid. So 3 located posteriorly, buccinator and masseter, 2 on the lateral side and 1 on the medial side. Right? So this is the, in total, you have how many? 3 and 3, 6 muscular attachments which are very important to understand. Right, so we will begin now with the lingual border of mandible, which is again very important from the clinical point of view. So we'll just have a look. What is very important? Lingual frenum. It is a frenum that will divide the lingual vestibule mainly into 2 parts on the right and the left side. Clinical implication is what? Presence of a tongue tie. That will restrict the movement of the frenum and that will also restrict your entry into the sulcus. You will not get sufficient width of the vestibule for you to have a denture flange in that region. But what I'm interested more is discussing about your mylohyoid muscle. Now, all of you are aware, mylohyoid is the muscle which makes the floor of the mouth. So the muscle that makes the floor of the mouth, FOM, is the mylohyoid muscle, right? Where does it origin from? It originates from the mylohyoid ridge that is located on the lingual border. So mylohyoid ridge located on the lingual border of mandible is where your mylohyoid muscle originates from. Mainly, how is it? It is very prominent in the molar region, and then gradually it tapers down to your anterior region. So cross-sectionally, if I have to draw it in terms of mandible, if this is your bony area, right, in the molar region, it is located quite high, the attachment. But when we go to the anterior portion, that goes slightly downwards, right? That will go slightly downwards like this. So that is how the muscle attachment of your mylohyoid muscle is. It mainly governs your floor of the mouth. Muscles are present in the mylohyoid region. They go to the hyoid bone. Now, clinically, what is important is you cannot go beyond the mylohyoid ridge during border molding and put your denture border beyond that. 0.5 to 1 millimeter beyond the mylohyoid ridge is tolerated, but nothing if you go under that too much. The moment actually contraction happens, the entire denture will be elevated. That is the problem that occurs. So we need to palpate our lingual border very thoroughly and identify the floor of the mouth muscle, which is a mylohyoid, and then understand how the movement is happening. It is different from patient to patient, and then probably do our border molding and mainly construct your denture border. So posterior part mainly of your denture is affected because it is higher up rather than the anterior part, because the mylohyoid ridge is higher up and the mylohyoid muscle is also higher up. That is why the posterior border is mainly affected here, right? Now, that is about your mylohyoid muscle. Briefly, now we will discuss about your alveo. Just give me a second. About your alveolo-lingual. Just a second. क्या आप एक बार मैसेज हाँ रिकनेक्शन हो चुका जी 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 ठीक है पर ये पेन क्यों नहीं चल रहा है ये पेन भी तो नहीं चल पा रहा है पेन नहीं चल रहा है ये तो नहीं चल रहा है मेरे फिंगर जेस्चर से हो रहा है बट वैसे पेन नहीं चल रहा है एक मिनट मैं चेंज करवा देती हूँ अनिल भाई सेल चेंज करे आप जो पेन ना प्लीज पेन नहीं चलती નથી ચાલતી. परविंदर जी पेन नहीं चल रही है. I hope students you are now again able to see. Just drop me a message on the Telegram group. Please refresh and join back. Are you able to see? Please put in a thumbs up or message so that I get to know that whether or not you're able to see. Okay, good to go. So majority of students are saying that they are able to see. They're good to go. So let's discuss alveolingual sulcus. We are sorry for the technical issues that you're facing, but after all, it's a mechanical device. Things can happen here and there, right? So let's start with your alveolingual sulcus. And understand the lingual anatomy or lingual border anatomy of mandible. So alveolingual sulcus mainly divided into three parts. Anterior part, we have our middle part, and we have our posterior part of it. They are not parts as such in the patient's mouth. For our own understanding, we divide it into three main parts. So let us understand what anterior part is mainly. Anteriorly, if we see, it is also called as the sublingual crescent area or the anterior sublingual fold. That is another name for anterior alveolingual sulcus. Where does it extend from? It extends from the lingual frenum to just starting point of mylohyoid ridge portion. So where the sulcus curves, that is just exactly where the anterior part is. Now this anterior part, what different structures or muscles are going to affect it? So mainly it is influenced by your genioglossus muscle. Now genioglossus muscle, just take a moment to understand, goes from genial tubercle to the tongue. So anteriorly you have your genial tubercles, it goes to the tongue. So this muscle is going to influence the anterior part of your alveolingual sulcus. Second is it is going to be affected by the fold which is present in the midline, which is your lingual frenum. If it is short or if it is higher, it is going to affect the height of your anterior lingual sulcus. And anterior portion of your one salivary gland, just think over it, which salivary gland? Your sublingual gland. So anterior portion of your sublingual gland. These three structures are very important that influence your alveolingual sulcus, right? What do we see or how do we register it? Whenever tip of the tongue touches the anterior part of the palate, that is how you register the height of your alveolingual sulcus's anterior border. When I take a border molding, I'm going to explain it in much details to you over there. Width of the sulcus that is maximum permissible is 2 millimeters. You cannot permit a thicker border here, otherwise it will just dislodge your denture, right? So that is about the anterior part. Talking about the middle part of the alveolingual sulcus, that is called as the mylohyoid area, because it is the area where actually the mylohyoid muscle is located. So it extends from the pre-mylohyoid fossa, goes to the distal end of the mylohyoid ridge, right? So it is the area around, or rather in the region of your mylohyoid ridge. Now this is a slightly shallower area because of the presence of the muscle. It is a slightly shallower area, and the curvature that you see here is mainly due to the prominence of the muscle. You see a curvature of the muscle, the impression border here, mainly due to your prominence of the muscle which is present here. So our applied anatomy here is what? We tend to mold our denture border towards the tongue, towards the midline. It becomes concave like this. So the denture border, when it is concave and it goes towards the midline, our tongue will rest over it. And when it rests over it, it imparts its stability. So the middle area of the lingual flange, the middle part, is made to slope towards the tongue. And when it slopes towards the tongue will rest on it. The tongue rests on it, and this imparts it stability to your denture, right? So that is how your second, or the middle part of your alveolingual sulcus is. And coming to the distal or the distolingual, posterior is also called as the distolingual part. Any overextension, I'm just straightforward giving you one question here, which comes very commonly. Any overextension here will do what? What is the alarming point here? Difficulty in, just think over it, what will happen? Difficulty in swallowing. Any overextension in the distolingual area, it is very alarming. It leads to difficulty in swallowing if you have an overextension here. So why does this happen? Let's understand the anatomy here first, right? So anatomically, this is the retromylohyoid region. Why retromylohyoid? Because it is located behind the mylohyoid ridge. So that is why it is called as the retromylohyoid region. From here, the flange of the denture will pass into the retromylohyoid fossa region. That means the posterior part of your denture. You see a specific S-shaped curve. You see a S-shaped curve that is formed because of the intrinsic and the extrinsic muscles of your tongue. So a very specific S-shaped curve of your impression is formed because of the anatomy of the different parts of your alveolingual sulcus. Mainly, what is very important for the posterior border is the limit. The posterior limit is governed by which muscles? Palatoglossus mainly, and superior constrictor. So if you have a weaker superior constrictor, or rather superior constrictor has a weaker influence, main influence is your palatoglossus muscle, which is going to determine your posterior limit or posterior border of your denture. So this region is sometimes also called as the retromylohyoid curtain region. And here also there is a specific bulging that happens. When the medial pterygoid pushes or contracts forcefully, it can create a bulge in the retromylohyoid curtain. So a bulge in the retromylohyoid curtain is caused by your medial pterygoid muscles forceful contraction. Another bulge that we studied was your masseteric notch, which was, again we revise, influence of masseter on your buccinator muscles. So this is about your alveolingual sulcuses that we see. So together what we have seen in mandible is supporting structures and your limiting structures. Now coming on to your relieving structures of mandible. Just let us discuss the relieving structure. So, just a second. Relief areas of mandible, what are they? So we are coming towards the end of anatomical landmarks. I've taken almost close to 3 hours covering landmarks. That should show the importance of these structures because they will make the entire foundation of your complete denture learning with us. So first is mental foramen. Now, as I very briefly explained in the beginning, when any nerve and vessel will pass through a foramen, if you compress it, it leads to paresthesia. So that is why mental foramen is blocked. Now, this one thing that we need to understand here, supposedly, this is the mental foramen here. As and when resorption occurs, I'm drawing the resorption here in orange. So as and when resorption occurs, the crest of the ridge will come down. And this particular mandible will sooner have a mental foramen close to the crest of the ridge like this because the resorption of this particular part has occurred, right? And it becomes closer. This is where it causes problem. This is where you are supposed to give it adequate relief because now there is a very good chance of paresthesia here and pressure will cause paresthesia and an altered sensation. So this usually occurs in old individuals. We are in 70s, 80s or someone who is a very old denture wearer, wearing it since years, and you see mental foramen right at the crest of the ridge. So the foramen does not travel. The crest is going down because of resorption. So another applied question, I recently said it to you, we will teach you certain extra questions also, is a study done by Vikal and Scoop. It is a study done by Vikal and Scoop. What does Vikal and Scoop say? If you want to identify the resorption that is happening, or rather the original height of mandible, consider the distance of mental foramen to the base of the mandible as x. From the mental foramen to the base of the mandible as x. You identify it on a OPG, right? This technique is done on an OPG. Multiply it by 3 times and that is your original height of mandible. Original before your residual ridge resorption started, 3x what is your original height. So I'll write it down. 3x will be your original height of mandible. This is a study done by Vikal and Scoop. The reason why I'm telling you this is, this has a chance of coming in exam on the basis of the trends that I've observed and what I have read and studied through your different MCQ patterns. There could be a question on Vikal and Scoop study. You don't go around reading all studies, but this is a specific study which I see can be asked because it covers aging, it covers resorption, it covers landmarks. It ticks all of the boxes that could be asked in our exam. So this is a important point. You can actually remember this, and this is very easy. 3x the distance from mental foramen to the base of the mandible would be your original height of your mandible. Now coming on to our second feature, or rather the second relieving area that we see is our genial tubercles. This is very easy. Probably you all would be knowing it. There are 2 in number. You have the upper one attaching to genioglossus and the lower one attaching to geniohyoid. Now, with your genial tubercles also, the same thing happens. When resorption occurs, the crest will come low and the attachment of the genial tubercles initially on the lingual border was somewhere over here and the muscle attachment was like this. When the crest has resorbed and it becomes flatter, the tubercles come towards the surface after resorption has occurred. right? So tubercles will come to the surface. That is when you don't have any sulcular height remaining, and there is a very good chance that your denture can get actually dislodged. So that is with your genial tubercles. That is why it requires your relieving area. Third important point that we need to read or understand is about torus mandibularis, which we see very commonly in mandible rather than seeing a torus in maxilla. So what do you mean by torus exactly? Torus is an exostosis of bone. It is an exostosis of bone which is present. That is called as a torus or a tori, right? More commonly seen in mandible than maxilla. In maxilla, it is located in the palate. On mandible, it is located on the lingual border, usually in the middle portion of the alveolingual sulcus. It is a completely benign overgrowth of bone. The problems that we face with torus is what? It will prevent the sulcular heights. It will prevent actually impression material going there. It will not give a smoother path of insertion. If it is very large in size, you will not be able to block it out under your denture. Then probably you need to go for surgical removal of it, or probably see at other means of your prosthesis or any other fixed prosthesis that could be employed. Because if it is a larger tori, then it will remove a very big chunk of mandibular bone and eventually leave the mandible in a weak condition. So we need to then look into alternate means of prosthesis fabrication rather than giving a denture. So these are the problems with tori, palatinus, as well as the mandibularis. So together here, I think we have covered the complete portion of your maxillary mandibular anatomical landmarks, a very, very, very important topic that we have covered till now.